Really excited to have so many smiling faces early on a Sunday morning. For those of you I don't know, my name is Kathleen Newbold, and I am the Regional Education and Support Manager for the Crohn's and Colitis Foundation of America Northwest Chapter. And before we get started with our program today, we've got some great educational sessions, and then and later in the morning, our kids and teens can go down the hall. But before we get started with that, we just wanted to tell you a little bit about the Crohn's and Colitis Foundation and what we do here, and kind of set the day. So the mission of the Crohn's and Colitis Foundation is to cure Crohn's disease and ulcerative colitis and to improve the quality of life of the children and adults affected by these diseases. So that mission's got two parts to it, right? So one side is a cure. We are doing fundraising to get research into all areas of Crohn's and colitis. So looking at the cause, looking at how to cure this, looking at how to ultimately prevent disease onset in high-risk patients. So funding the most promising research through a peer-to-peer, review system. And last year we invested $22 million into research, and the most promising research. We also provide education and support programs to help folks out in the meantime until we have that cure. Things like this education program today, online webinar programs so that you can get education wherever you live and at any time. They're on demand on our website. And also the Camp Oasis program that you're going to hear about a lot today. It's a special camp just for kids with Crohn's and colitis where they get to be carefree for a week. And feel normal, and like there's nothing wrong with having to run to the porta potty, or if you have to take pills with your meals or whatever that is, and it's getting to be just a normal kid for a week. I guess I'm done. No. But with the safety net of medical staff, volunteer medical staff, many of whom are here today, who are there to support our kids with IBD. And also cabin counselors who also have IBD and can understand what our kids are going through and can help them out. So that's Camp Oasis. We also have support groups in the area, and there's a sheet in your folders asking about interest in a parent support group that we hope that you will fill out and leave with us today. Also in your folder, there's a bright pink evaluation form. We hope that you will fill that out. Let us know what you thought of the program. We really value your feedback and read those and look for ways to improve our future education offerings. Also in your program, there's some blank pages to take notes, and we also have some paper up at the front desk. And we'll have the slides posted next week, and I'll send out a link to everybody so that you can see the slides and review those on your own. I've just hogged our whole time. I'd like to introduce Dr. Ghassan Wabe, who is the director of the IBD Center here at Seattle Children's Hospital, and he's also a member of our board of directors and the chair of our chapter medical advisory committee, and the Camp Oasis co-medical director at Camp Oasis here in the Northwest. So thank you, Dr. Wabe.
Thank you so much. Thank you, Kathleen, and I want to thank Teresa as well for leading this incredible conference time and again. So thank you, Teresa. Welcome, everybody. It's wonderful to see so many faces, new faces, and old friends and old new friends. Thanks for coming out on a Sunday, on a beautiful Sunday, if I may add. It's great to be here together with everybody. Part of our mission at the IBD Center at Seattle Children's is not only to bring you the best specialists, the best care, the best focus on research today and research towards a cure, but also to make sure that we have these events to have a dialogue together about what's new, what do we know, bring you up to speed on pretty much the big picture today in IBD, and also get your feedback. And as Kathleen said, it's so important to hear back from you, things that we can do differently, things that we can do better. We always learn from our patients, and we thank you for your feedback always. Today you have a really wonderful list of incredible speakers, specialists, some of the most experienced people in their field, in their subfield, I would say, in IBD. As we all know, IBD has grown so much over the past 2 decades, and all these areas of focus in IBD blossomed as areas that need really a dedicated focus and attention. And that's where we, have been super fortunate to have different experts come together on the same day in one center and also dedicate their time on a weekend to come here and speak to us all. So I want to thank the speakers for being so generous with their time. And again, I want to thank the parents, because without the parents, without that team, really we cannot do a whole lot for our kids. So thank you again for taking the time to be here. It is my honor and delight to introduce the first speaker, Dr. Dale Lee. Dr. Lee joined us from CHOP. He is an expert in inflammatory bowel disease, and he has a very specialized focus on nutrition in inflammatory bowel disease. As we all know, there is a huge amount of focus on nutrition in IBD, not just balanced nutrition, but also nutrition as a way to modulate the disease, to change symptoms, to change inflammation at times. And we're so grateful that we got him to come to our center. Dr. Lee is very generous with his knowledge, up to date, up to speed. He's my go-to guy with questions about nutrition. And please join me to welcome him, and I'm looking forward to hearing his excellent talk. Thank you.
So I'd like to thank you all so much for the opportunity to join together in this conference. I think this is a conference where, as much as we share the latest information with you all, we can learn so much from you guys as our patients and sort of as our partners as we care for our children with inflammatory bowel disease. As Dr. Wabe mentioned, I came most recently from the Children's Hospital of Philadelphia. And one of the main things that attracted me to Seattle Children's Hospital was sort of the opportunity to work with a really excellent team of IBD experts, people that want to collaborate, push forward the research, and also very interested in learning about how we can make therapy better for kids with IBD. In particular, sort of the idea of how do we recommend specific diets for kids with IBD, and how can we use nutrition? That's my personal interest. I'll touch on that a little bit this morning on my talk, but really the goal for this talk is to kind of, in broad strokes, talk about what do we know about IBD. So some of the things that I'm going to specifically touch on. So what exactly is inflammatory bowel disease? I'd like for us to just start from common ground zero for the rest of our morning and discussion. What are the causes of inflammatory bowel disease? I think there's not a very clear-cut answer, but I do want to discuss what we do know as scientists and as clinicians so that we can share that with you all. Next, how do we best treat inflammatory bowel disease? I don't think we know the exact answer, but we are gradually learning better and better what sorts of strategies to use and how to change therapy and tailor therapy to individual children and families. Next, I'm going to talk about what is the role of research. So Kathleen mentioned that the CCFA has really been a huge partner for us in helping us to have funds and organize research together. And that's what's really driving a lot of the information that we're going to be sharing with you guys this morning. And then finally, I want to talk about what don't we know yet. I think it's important to know what you know, and it's also important to know what sort of the deficits are in knowledge so that we can work forward to better understand those in the future. All right, so what is inflammatory bowel disease? As you guys most likely know, it's a chronic inflammatory condition affecting the GI tract, and it can affect anywhere in the GI tract from the mouth to the anus. There are classically two types of IBD, Crohn's disease and ulcerative colitis, and then there's sort of a middle ground form called indeterminate colitis. So for you all in the audience, you probably carry one of these diagnoses, and an important thing to remember is regardless of which type of diagnosis you have, a lot of the therapies are very similar. The causes are very similar. So even though you're assigned to a specific type of IBD, everything we're going to be talking about is pretty much applicable to everybody. So for the kids and the patients in the audience, I made a list of different symptoms. And as you look at this list, you'll probably say, yeah, I have that symptom, and no, I don't have that symptom. So specifically, symptoms you can have are diarrhea, blood in the stool, abdominal pain, you can have bloating after you eat, you can have poor growth, and you can have other non-GI tract symptoms. So I think the important thing here is we have to know that with inflammatory bowel disease, your presentation can be extremely variable. One person might have blood in the stool, one person may have no blood in the stool and no diarrhea either. So it's important that we think about inflammatory bowel disease as a condition that can present in a lot of different ways. So speaking of the different ways IBD can present, so we know that IBD can affect different locations. For some people, you'll have sores in your mouth. For other folks, you can have severe inflammation just at the very end of your colon. We know that IBD can act very differently as well, too. So one way that it can present is with just inflammation. Another way that it can present is with a stricture. And a stricture is when you have ongoing inflammation for a long period of time and narrowing of the lumen of the GI tract. As you know, when something becomes very narrow, it can be difficult for things to pass through there. So for some children that present with a stricture, they have difficulty with eating because it hurts, because things are too narrow. Another presentation of IBD is with a penetration. So this means that there's inflammation that's severe and that the contents of the GI tract go through the wall of the intestine. When this occurs, you can have something called a fistula, which is an open tract, or you can have an abscess form at some portion of your GI tract or within the abdomen or around the anus as well, too. The picture on the top right is a picture of a perianal abscess, and this is one presentation of inflammatory bowel disease, Crohn's specifically. So what do we do with this information? So based on our patient's age, their gender, the location of their IBD, and sort of how their IBD is presenting, we talk. So we talk with the families, we do some research, and then we talk about what are the best therapies for our children. So there's no one-size-fits-all for therapy. It really depends on the individual patient and a discussion with the families about what the needs are of the family and what the big concerns are. Okay, so what exactly causes IBD? You all might have thought this, especially for the parents. You may have thought, was there something that my child ate? Was there something that happened early on? So let me tell you a little bit about what we know about what causes IBD. We know that genetics play a role. So for example, if mom and dad are really, really tall, it makes it more likely that the child is going to be very tall. Genetics with IBD is a little bit more complex than that. In general, with IBD, if you have a genetic predisposition, you're more likely to have inflammatory bowel disease, but it requires additional triggers. For example, environmental triggers such as foods or antibiotics. And in this setting of environmental triggers, you have an immune system response and ongoing inflammation. So the inflammation continues, and it doesn't shut off appropriately. That's what causes IBD. So with genetics, I mentioned, so in general, genetics predispose you to IBD. That means it makes you more likely to have IBD, but it doesn't guarantee it. So in general, those of us that have inflammatory bowel disease may carry certain genes that make us more likely to develop inflammatory bowel disease. So again, it makes us more likely, but it doesn't guarantee it. On very, very rare situations, you can have a specific genetic defect that makes it so you definitely have inflammatory bowel disease. On the bottom left here, I made a little schematic. IL-10 is a specific inflammatory cytokine, so it actually is anti-inflammatory. So IL-10 binds to the IL-10 receptor, and it decreases inflammation in your body. If you have a defect in this pathway, for example, you lack IL-10, or your receptor does not function well, you will have inflammatory bowel disease. And this presents in very, very young children with severe, severe inflammation in their colon. This is an example of a single gene defect that can result in inflammatory bowel disease. This is much more rare than having inflammatory bowel disease that develops over time and is related to other environmental triggers. So we know a little bit about the specific genes that make you have an increased risk of having inflammatory bowel disease. This is a publication in 2012, and at this time there was 163 genes that were associated with inflammatory bowel disease. As of today, there's probably about 200 genes total that have been identified. If you look on this graph, it's extremely complicated, so let me just explain briefly. The top is Crohn's disease and a list of different genes that are associated with Crohn's. The bottom is UC and genes that are associated with ulcerative colitis. As you see here, a lot of the genes overlap. So greater than 80% of these genes overlap for ulcerative colitis and Crohn's disease. Certain genes seem to play a larger role. For example, on Crohn's disease, on the right side, you'll see NOD2. That's one of the most identified genes that has a strong association with inflammatory bowel disease. Okay? So what is NOD2? So it's a gene. It's involved in the body recognizing bacteria, and it also activates the immune system. If you have an abnormality with the NOD2 gene, you're more likely to develop Crohn's disease in the future. But I think an important thing is that there's a lot of people with, without inflammatory bowel disease that have abnormalities in the NOD2 gene as well too. So again, you have a genetic predisposition, but it doesn't guarantee that you get inflammatory bowel disease. Okay, so right now we know that genetics may increase your risk of developing inflammatory bowel disease. So how else can we use genetics? So in the future, we think that genetic analysis may help us better understand what therapies that our patients may respond to. This is a study or a graph from a study out of Germany. It's a doctor by the name of Sibylle Koletzko. She's one of the best IBD researchers in the world. And they looked at a specific nutritional therapy. They followed kids out over 360 days, and they looked at 3 different forms of a gene. So you have the green gene, the blue gene, and the red gene. This is all the same gene, but just different mutations in the gene. They found that for this therapy, on the left side here is percent in remission. 100% means you're doing totally fine and you don't have relapse of disease. 0% means that everybody has had relapse of disease. We see that the people with the green type of the gene, they had a greater percentage that stayed in remission over 1 year. If you had the red type of the gene, this therapy did not work well and almost everybody had relapse of disease. So in the future, as we learn more about genetics and how we can use it for therapeutics, we may be able to use that to say, this is a good therapy for you as a child versus maybe this therapy isn't as good for you. We're not at the point right now where we're going to be checking genetics on everybody, but in the future, this is something that we think is promising. So we know that the environment is important for inflammatory bowel disease. There are certain things in the environment that increase our risk of developing inflammatory bowel disease or even having a flare. So for example, we know that early childhood antibiotics may predispose to getting inflammatory bowel disease. We know that more Western countries, for example, with better hygiene, with more processed foods, societies, countries that are quote-unquote more advanced, they have a greater likelihood of people having inflammatory bowel disease as well. We know that certain foods are specifically associated with inflammatory bowel disease. And again, there's associations, but there's not a direct connection. Specific foods include certain types of fats. We also think that increased meat intake may be associated with a greater risk of inflammatory bowel disease. We know that certain environmental factors seem to decrease your risk of getting inflammatory bowel disease. Those include greater intake of fiber and vegetables. One really important thing that speaks to the importance and sort of the critical nature of environment is we know that nutritional therapies are effective for inflammatory bowel disease. So when you change the nutrition that somebody's eating, you're really changing the environment of the things that are in their GI tract. So we know that exclusive enteral nutrition, which our dietitian Kim Brawley is going to speak more on at the end of today, and also the specific carbohydrate, these are important dietary interventions that can result in changing the environment. They can also make it so that your inflammatory bowel disease is much better controlled. So a little bit about geography. So the kids in the audience may know these countries better than us adults. But here's just a map of the world. And in red, we see countries that have a greater incidence of inflammatory bowel disease. And in blue, we see countries that have a lower incidence of inflammatory bowel disease. If you look at the pattern here, you see North America, you see Eastern Europe as sort of the areas that have the highest incidence of inflammatory bowel disease. This was 1995. In year 2015 right now, you look and you see that many Asian countries, for example, South Korea, Japan, and China, they have a rising incidence of inflammatory bowel disease as well too. So really, the geography and sort of the modernization of countries seems to be associated with greater inflammatory bowel disease risk. So Dr. Suskind is going to speak a little bit more about the intestinal microbiome, but I wanted to touch on this briefly. So we know that the environment greatly impacts the bacteria in our intestines. For example, the food we eat, they change what's in our intestines. The bacteria that we're exposed to, they change the bacteria in our intestines. So we know that bacteria is important because they break down and metabolize quite a bit of foods and things that we eat. And also, very importantly, bacteria in our GI tract, they interact intimately with our immune system as well too. This is a picture here. In the green, you see our little finger-like projections of the GI tract epithelium. Right above that, you see a kind of pinkish mucus layer, and then those blue blobs are bacteria. So you see that they're interacting very closely. So what about the immune system? So in inflammatory bowel disease, at first, the immune system is stimulated, And when the immune system is stimulated, it becomes angry and inflamed, which is appropriate in certain situations to fight off infections, for example. But we don't like it when the inflammation and the activity of the immune system does not calm down appropriately. So we know that many of the medications we use for inflammatory bowel disease, they specifically calm down the immune system by suppressing the immune system. I have a little cartoon here. So we have an immune cell in yellow and then a bacteria in blue. So we like it when the immune system and the bacteria in our bodies, they can sort of be at peace with each other. In inflammatory bowel disease, the immune system and the bacteria and the immune system against our own body, they're fighting, they're upset, and they're angry. So this is a picture in the blue right here on the upper left. That's the lumen of the GI tract. So that's like the inside of your intestine. We have a little wall of the intestinal epithelium, which is the skin at the inside of our intestines. And then we have the inside of our intestines here. So normally we have bacteria in the lumen of our GI tract and sort of this protective lining that makes it so that bacteria don't get into the cells of our GI tract. When there's a breach in this barrier, bacteria can get inside the GI tract cells. Normally what we would hope would happen is that our body is able to fight off the bacteria and seal off this breach. In inflammatory bowel disease, unfortunately, the immune system doesn't have this sort of normal response, and this little trigger can make it such that you have ongoing inflammation that continues over time. So we learned a little bit about what causes inflammatory bowel disease. So how do we best treat inflammatory bowel disease? So we've learned over time that it's really important that we listen to our patients and our families. I think this is the #1 thing about treating inflammatory bowel disease. We as the medical team, we need to know the medical literature. We need to know all about the different types of studies out there, the different types of medications, and how the medications are good, and the potential side effects. We know that working with an IBD team is way better than trying to do things alone. One of the great things about Seattle Children's here is that there is a large variety of doctors, dietitians, nurses, nurse practitioners, psychologists. There's a huge team of people looking out for you and your family if you have inflammatory bowel disease. We know it's important to monitor the activity of your disease, and we also know it's very important to optimize medical and dietary therapies over time. So, listening to families. So when we have a child who's diagnosed with inflammatory bowel disease or has ongoing symptoms, it's really important for us as the providers to listen to the concerns that the child has. We really appreciate when you guys share with us what the concerns are. Sometimes it can be easy to just talk about how many times are we pooping a day? How does your stomach feel? But we also would love to hear about the concerns that you all have, how things are going in school, and what your fears and concerns are as well too. So that's very important. We evaluate symptoms, and we also gather information from your experience. So at Seattle Children's Hospital, there are a lot of families that have talked about how nutrition seems to help their disease. So because of the sort of information that we've heard from you all, we've been able to better study dietary therapies in inflammatory bowel disease. So really, we learn as much from you all as you all learn from us. So knowing the medical literature. So we know that personal experience is important. So for example, if I have a friend that tells me, I just went to a really great restaurant, I may be interested to go to that restaurant. I may also go online to Yelp and take a look at all the reviews and see what other people say as well too. So personal experience is important, but with inflammatory bowel disease and medications, we also know that organized medical studies are able to provide us high quality data. So this is a little bit more objective than a single person experience. So I created an example right here. So I want to buy a new car, and my friend tells me this purple Dodge Caravan is like the best car ever. So I could take that advice and say, that sounds like great advice. I'm going to buy a purple Dodge Caravan. Alternatively, I could do some research online and I could look what the experts say about what the best cars are. So in my mind, we have to listen to the opinions from our friends, but we also have to take in context sort of what the experts say as well too, and what the sort of very rigorous studies show. So clinical trials are one way that we as clinicians can learn about how medications and how therapies can be effective. So clinical trials are specifically able to isolate the effect of a particular therapy. So there's a lot of different things that can potentially impact outcomes, but clinical trials are designed to look at exactly how does this medication or how does this therapy result in things getting better or worse. So clinical trials, they can distinguish from by chance or circumstance versus truly being effective. So that's the important thing with a clinical trial. They take a lot of money and a lot of effort to do and plan, and the CCFA has been great in supporting us. But these really help us give you all some more firm answers about what therapies are good and what therapies are not as good. So I spoke a little bit about working with an IBD team. So working with a team is way better than trying to do things all by yourself. We have these minions here. This single minion is not going to be able to screw in this light bulb, but this team is going to have a little bit better effort. So our team is really, first and foremost, the child or the adolescent with inflammatory bowel disease and the parent. Thereafter, we have a team that's supporting you guys. It's the physician. We have nurse practitioner, physician assistant. We have dietitians that are very specialized in inflammatory bowel disease. We have a wonderful psychologist, a team of nurses, and we have just hired a social worker. So we're excited about that. So working with a team, so really when we're talking about the successful treatment, the different team members are able to kind of help us look at these different things that define successful treatment. So first of all, we're looking at getting the inflammation under control. We're looking at nutrition and growth. We know that it's very important to give our patients and our families appropriate guidance in getting enough calories in, as well as giving appropriate guidance in how we're supporting growth. We know that supporting the psychological well-being of a child is very important. If your inflammation is under complete control, but you're having a really hard time with your diagnosis, not attending school, we don't think that you're having very successful therapy. We need to work harder on getting things better for you. We also want to make sure that the children and our adolescents are feeling independent and successful, and Teresa's going to talk a little bit about this today. So monitoring disease activity. So we know that symptoms are very important. So nobody likes to have bloody diarrhea, have to run to the bathroom frequently, and nobody likes to have belly pain. We also know that healing of the GI mucosa is important. So here on the upper right here, we see a red view of the colon, and we see a lot of inflammation. The white stuff is inflammatory exudate. So that is an inflamed colon. So one important thing that we as researchers and as clinicians have learned is that having no symptoms does not mean that the mucosa is totally healed. Alternatively, you can be having a lot of abdominal pain and symptoms, but your GI tract mucosa could be well healed. So there's a difference between symptoms and inflammation. And it's our job with you to figure out the difference, because if you have ongoing inflammation, we may need to make an alteration to your therapy and increase immunosuppression or change dietary therapy. But if it's symptoms, we can potentially use other approaches and not change medications. So how do we assess for objective inflammation? So you guys are probably more expert in this than anybody else. So you know that we check labs for you all. So labs can indicate inflammation and blood counts. We check fecal calprotectin. You all are probably experts in collecting stool and submitting these samples, but fecal calprotectin is one marker of inflammation that we can look at in the stool. It really does a nice job of helping guide us to know if there's active inflammation in the intestines or not. Imaging studies like MRIs, ultrasounds, x-rays, those can be important for us. And finally, you all have undergone endoscopy. So this is direct visualization of the GI tract mucosa to get an idea of inflammation. And also we do the biopsies or skin scrapings, and we look at things under the microscope. Okay, so when we monitor disease activity, how do we tell if there's active disease or not? So this is a study that I did, and it's very telling because it compares symptoms to fecal calprotectin. So symptoms are kind of what we describe. Calprotectin is a hard number, okay? So if you go with me here, on the left side of this graph, it shows percent achieving outcome. The red outcome is resolution of symptoms, and the blue outcome is a low fecal calprotectin. If you look at just the red, you see that there's a difference, but it's not very pronounced, right? So I would make the argument that these three therapies look fairly similar if you look at only the symptoms. If you look at the blue outcome, which is fecal calprotectin less than a certain threshold, we see that clearly this therapy at the far left is not as good as the other therapies. So for us as clinicians, we want to talk and we want to listen about symptoms, but it's also very important that we look at these objective markers because they tell us, and sometimes the symptoms are not as good at differentiating success versus a not success. All right, so how do we optimize medical and dietary therapy? So as you guys well know, each individual responds to therapy quite differently. medications are more effective for certain people than other people. We know that the dosing of medication is different based on the individual patient. We know that nutritional therapy works well for some people and just doesn't work well for other people. When we're talking about therapies, there's absolutely a risk and a benefit that we're trying to balance. It's probably, I would say that balancing the risks and benefits of IBD therapy, probably harder than balancing rocks like this. And I think that looks pretty hard. So you as the families, you guys are under quite a bit of, you have a great responsibility when we talk about the right therapies, and our job is to guide you, provide you the information, and give you our recommendations on what we think is the best therapies. Another thing is, so what about combining therapies? So clearly, one therapy plus another therapy, you'd expect that it equals two therapies together. Not always. Certain therapies actually work in sort of a combination fashion and are greater than the sum of their individual parts. So one therapy plus another therapy can sometimes be greater than the efficacy of just two therapies. So drug monitoring. So some of you may be on a medication called azathioprine or 6-MP. We know that with this medication, we can monitor drug levels. So if you're on these medications and you're not feeling well, we will talk to you in clinic. We'll check some labs. We may check a fecal calprotectin. But one other thing we can do is check a level of the metabolites of this medication. And based on that, we can alter your dosage and try to get things under better control. So some of you all may be on Remicade or Humira. So these are medications. We're learning more and more about measuring the levels of these medications. So we have the ability to measure the amount of Remicade or Humira in your body. We also have the ability to measure the amount of antibodies to Remicade or Humira in your body. So if you're not feeling well, we can check these levels, and based upon the levels, we can make some tweaks to your therapy, or we may say, maybe it's time to consider a different therapy because these aren't working well. So with nutritional therapy, some of you may be on exclusive enteral nutrition, which is a formula-based therapy. Others of you may be on the specific carbohydrate diet. So when you're on these and you see us, we can actually optimize these therapies as well too. We can talk about, do we need to be a little bit more restrictive with foods? Do we think that we're okay to add a few more foods into the mix? And in addition, if you're on nutritional therapy, sometimes we can talk about the value of adding on some medications as well too. Sometimes nutritional therapy plus medicinal therapy together are a very good combination. So we talked a little bit about the risk and benefit of IBD. So one thing that a lot of families are very educated about and ask us a lot of questions about is, so what is the risk of being on this medication? So I think lymphoma or cancers are one thing that families are very concerned about. I think absolutely we as clinicians are concerned as well too. That's why we want to see you back in clinic, do careful physical exam, check labs regularly. I wanted to put up a couple slides just to put into context sort of the risks associated with inflammatory bowel disease medications and the risks of certain kinds of cancers. So we know that in adults, the baseline risk of lymphoma is 2 in 10,000 per year. So if you see here, there are 2 blank spaces, so that's 2 in 10,000. Here is a graph showing 4 in 10,000. So we still see it's a pretty small risk overall, right? Here's another graph showing 6 in 10,000. So baseline risk for lymphoma in adults is about 2 in 10,000. Studies in adults on inflammatory bowel disease medications, in particular azathioprine, show that the risk of lymphoma rises to approximately 4 to 6 in 10,000. So to put this into context, there's absolutely a risk with being on certain medications. But if you look at these graphs, I'm going to go back to 2 in 10,000. 2 in 10,000, 4 in 10,000, 6 in 10,000. Clearly, there's an increased risk, but it is a small risk. We want to talk to you guys about it. We think it's important to discuss, but there are risks, and there's also benefits to medications. So what is the role of research in inflammatory bowel disease? So the data that I shared with you all, the data that most of the people after me are going to share with you all, it all comes from research. And research is the systemic work to further knowledge. So being a student in school is kind of being a researcher. So what does research produce? So first of all, it helps us to understand what is the mechanism of inflammation in IBD. So why is this inflammation ongoing? If we can understand the mechanism, we can target therapies better. So what are innovative new therapies? This is what research is producing. So these people that are doing research, including our team here, we're helping to develop and refine new therapies for IBD. From research, we're able to gather information about how effective therapies are, And we're also able to gather information about the adverse effects associated with therapy as well too. And with this information, this is all stuff that we can share with you all so you can make good decisions about which therapies you'd like to pursue or which therapies may not work as well for you. So one important thing about research, the majority of IBD research is in adults, and the majority of IBD research involves medications. Oftentimes what happens is we look at the adult research information and it trickles down to pediatrics, and we do have some pediatric trials as well too. So we're a little bit behind in research compared to the adults. But when we talk about nutrition research, this is much more prominent in pediatrics than adults. And Seattle Children's is a center where nutrition research is really, we're one of the leaders in the United States as well as the world in nutrition research. So really what's going to happen is the research that we produce about nutrition here is going to trickle up to the adults, and they're going to be looking to us for guidance. So how can you all be involved with research here at Seattle Children's? So some of you at your clinic visits have probably filled out these little forms that ask you about how your symptoms have been doing. Belly pain, number of bowel movements, things like that. So we are involved with Improved Care Now. So Improved Care Now, or ICN. Chi-Chi is right here taking pictures. Can you raise your hand? So you may have met Chi-Chi. She's our ICN contact. She's done a phenomenal job of helping to coordinate our ICN program here. What we're doing with ICN is we're gathering data from your clinic visits. It doesn't require any additional effort on you guys. We're gathering information about what therapy you're on and how effective the therapies are doing. And this information is being collected all around the world. And when you collect a lot of information and you look at it in a systemic fashion, you can come to conclusions about maybe this therapy is good because of this reason. Maybe this therapy is more associated with certain side effects. So ICN is a wonderful thing. And if you are not involved with ICN and you're interested, please ask your GI doctor at the clinic visit. This is something we'd love to have all of you enrolled in. And we think that it can hopefully make therapy better for you guys going forward. Clinical trials, these are studies specifically designed to evaluate the efficacy of specific therapies. So here at Seattle Children's, there's a variety of clinical trials going on for medications as well as nutritional therapies. And really, this is allowing us to look at new therapies as well too. And if we're going to be starting a new therapy, we really need to collect information in a systemic fashion. So we want to know how effective the new therapies are and if there are any side effects. So this is the research that's going on here at Seattle Children's and more broadly in the IBD community. So finally, I want to talk about what we don't yet know about inflammatory bowel disease. So clearly we've learned a lot over the past 20 years or so, but we have things that we still need to learn more. So why is IBD becoming more common? Is it just related to the environment, or is there something else going on? Are we just way too clean for our own good? We need to learn a little bit more about why IBD is on the rise. How long will my child or my adolescent need to be on a particular therapy? I get this question a lot. We're not exactly sure. There are new therapies constantly being developed, and as we learn, our job is to share them with you guys. Why are some therapies more effective in some people versus other people? We don't exactly know yet. Maybe it's genetics, maybe it's something else. This is something that we need to better study. And finally, how can diet and other therapies be used to change the intestinal microbiome? So Dr. Suskind, who's going to speak next, is going to speak a little bit to this, but it's something that we would love to better understand. So we know IBD is a chronic condition, and we also know that it does not have to limit you. When you're ill, you're not going to feel well, but our goal is to have you feeling well and doing whatever you want. So this is a slide. Does anybody know what these people have in common? They're famous. So these people, so this is the 34th. Do we have any hands? Yes. You're exactly right. These people all have inflammatory bowel disease. These are all extremely successful people. The 34th president of the United States had inflammatory bowel disease. Sunny Anderson, who's a Food Network chef and host, she has inflammatory bowel disease. A quarterback of the Jacksonville Jaguars, I don't think presently, but he has inflammatory bowel disease. I put a picture of a girl doctor. I have numerous friends who are GI doctors, and they have inflammatory bowel disease. So if you are in the audience and you have inflammatory bowel disease, you can really be whatever you want. You can be a president, you can be a professional athlete, you can be a star on TV, you can be a doctor, and we want you to know that you can be very successful if you have IBD. All right, to briefly conclude, IBD is a chronic inflammatory condition. IBD develops in the setting of a genetic predisposition, environmental trigger, and ongoing inflammation due to an abnormal immune response. Treatment of IBD really is most successful when you have a team working behind you. Research is helping us to develop newer and better therapies. And as we, as the GI team, as the IBD Center, learn more about inflammatory bowel disease, our job is to tell you guys about the latest and greatest and how things can be used to help you feel better. All right, thank you guys.
Thank you, Dr. Lee. So now, as we transition speakers, I want to invite all of our kids and teens in the room to go to a special kids and teens room where we're going to have some activities there. If your child has an allergy, especially a nut allergy or any dietary restrictions, would you please let Heidi know? Heidi is going to be our lead in the kids and teens room. Please let her know if there are anything like that that she needs to know while she has your child. The kids and teens room is just down the hall and to the right past the bathrooms. So if you need to reach your kid, that's where they'll be. But Heidi will lead the group there now. On that note, restrooms are down the hall. Turn right before you leave the building, just so that you know where those are.
All right, it is my great pleasure to introduce my colleague and friend, Dr. David Suskind. Dr. Dave Suskind has been a leader locally, nationally, and internationally, exploring concepts in the microbiome and the notion of fecal transplantation in modifying disease, whether it's infection or IBD. He's a pioneer in that field. I'm honored to introduce him as our next speaker on what is the microbiome and why should we care.
We throw the words around ulcerative colitis, Crohn's disease, indeterminate colitis, and in actuality, we do that because it simplifies all of our jobs. It simplifies us because we can kind of put in individuals into different categories. But I think, as Dr. Lee pointed out so amazingly, is that really everybody's IBD is unique to him or her, and we really have to find treatments and therapies for that individual. And one person's experience is going to be very different, obviously sharing some commonalities, but very different from another person's individual experience. And so today we're going to talk a little bit about understanding IBD and not focusing on the immune aspect of IBD, which is the aspect that a lot of times we look at, but looking at it from a different perspective, from that of the fecal microbiome. And just being in academics, we always put disclosure statements, so I have nothing to disclose. Really, we're going to talk about the etiology. Actually, let me stop for a second. The other thing that I actually want to do before we go into the talk is actually open up this talk to anybody at any point. So if somebody has a question, because sometimes I throw around words that I actually don't even understand, and so if anybody has a question at any point during this talk, just stop me, because I think the best and the most important way of learning is really through interacting. So feel free to just raise your hand and say, what did you mean by that? Or I didn't understand that, or could you go over that again? And I think that would be fantastic, not only for me, but for everybody. So we're going to talk about the etiologic, or the cause of IBD. Again, focusing not on the immune aspect, but really looking at the fecal microbiome. And when we look at the fecal microbiome, the bacteria within our GI tract, we really have to look at not only the bacteria, but what our body is doing with that bacteria, the immune homeostasis, or how does our immune system deal with these 100 trillion bacteria. And then we're going to talk a little bit more about the fecal microbiome and focus a little bit on diet and what our experience here at Seattle Children's is and how the diet may modulate the fecal microbiome as well as our own clinical experience. So this is a picture that I think a lot of people have seen. I have changed it slightly. Usually you see three big circles: the immune response, environment, and genetics. And I actually simplified it a little bit because really when we talk about IBD, we're talking about an immune response. We're talking about your immune system, which is attacking the GI tract or other parts of the body. And what we think right now, and where there's really good evidence, is that the GI tract is attacking the body because of the microbiome, because of those bacteria within the GI tract. Now, we know there is a genetic component. As Dr. Lee so aptly pointed out, there is definitely a genetic component to this disorder, this disease. And that genetic component actually affects the immune response. And we know there's an environmental component. And we know that environment is most likely affecting the microbiome. And when we look at the genetics, we see that there are over 163 genes linked to IBD. Now, there are other genetic disorders out there. We think of cystic fibrosis, right? I think many of us have heard of that. There's one gene associated with that. Celiac disease. There is just two HLA components that are associated with that. But for inflammatory bowel disease, there are 163 that have been linked to IBD. 30 of those associated with Crohn's disease, 23 associated specifically with ulcerative colitis. And as I mentioned before, the genetics affects the immune response. And it's in different areas that the genetics are affecting the immune response. But if this was truly just a genetic disorder, we would just see the same amount of IBD going on throughout the world, and we wouldn't necessarily see any increase. But what we've seen in the last 50 to 60 years is a fairly stark increase in IBD. But we don't only see an increase in IBD, we see an increase in all autoimmune disorders. And so we have to think outside of the box of just our genes and really start looking at our environment. And when we look at our environment, as I already mentioned, we think about the microbiome and how that may be affecting individuals in the development of IBD. But I like history. History, I think, is fantastic. And I think by looking at history, we get a better semblance of why IBD may be increasing. So in the 17th century, a fellow named Antony van Leeuwenhoek invented the microscope. And before that, we had no idea that there was this microscopic world that occurred. And as he presented his data to the British Royal Academy, which is a pretty impressive thing to do for a 17th century Dutchman, he said there are more animalcules, which are the bacteria, the microbiome, in his mouth than there were people in the New Netherlands. And yes, that tells us he was a very bad brusher. But it gave us another insight. It told us that there was another world that may actually be affecting our overall health and well-being. And since that discovery of the microscope, there have been many, many scientific breakthroughs made, and primarily on pathologic organisms. So organisms or bacteria that are overtly causing disease. C. difficile, E. coli, salmonella. We've heard these words before, and that's where the science is focused on. And it wasn't until about 4 centuries later that a fellow named Joshua Ledberger defined the microbiome. And he actually was a Nobel award-winning scientist, and he defined the microbiome as the ecological community of commensal, symbiotic, pathogenic microorganisms that literally share our body space. So what does that mean? That means all the stuff that's on us and in us and around us. That's the microbiome. Now, as a GI doctor, I know that the most important part of the microbiome is within the GI tract. Dermatologists may disagree or pulmonologists may disagree, but for me, it's within the bowels. But we're not scientists, or we're not all microbiologists. And so really, to understand the microbiome for the majority of us, I think a picture really serves the purpose. Looking at this picture of a very minuscule component of the microbiome, this is, the tip of a pin that's been divided 50 times, just a really small component. You see that the microbiome is not only quite beautiful, but it's diverse. The organisms are interacting with each other. And what else it's doing? It's interacting with the host. It's interacting with us. We may not be aware of it on a daily, minute-by-minute basis, but it is. So what is this fantastic thing that we call the fecal microbiome? Well, it's 100 trillion microorganisms. And 100 trillion is about 15,000 times the people there are in the world. So when you think about that, and they're all just within our GI tract, you can really understand the impact that it can have. And it makes about 2 pounds, in the human gut there is about 2 pounds of bacteria, so you can start subtracting that from the scale at this point. But when you look at it on a weight basis, right, the human, the human cells take most of the weight. So it's 99%, we're 99% human by weight, and maybe 1% bacteria. But when we start looking at it from a cell-to-cell basis, the cells in the microbiome, the bacteria, actually outnumber us. So if there was a vote 1-to-1, we would lose. And it outnumbers us 1-to-10. But if we actually go even further into the data and look at the genes, and remember, genes are what makes us human, right? It's our genes who make us who we are, as well as our environment, but very important. But then we become actually a minuscule part of who we are, because the genes encoded in the bacteria are about 3 million, and that makes us now only 1%, and the bacteria 99% of who we are. Now, bacteria wasn't there always. So when we're in our parents' wombs, when we are before we are born, we're pretty much in a sterile environment. So there is no bacteria. But as we are being born, whether we're born via C-section or via the birth canal, we get colonized. And depending on how we're born, we actually get colonized with slightly different type of bacteria. And as we all, because we all have children, we all know that the stools of babies are very different from the stools that we have as adults. And that is actually because of the microbiome and also of what they're eating. And it really isn't until the end of the first year that you start to get a picture of an adult microbiome. And it's not really until 3 to 4 years that you can really kind of get a better semblance that this is probably, this could be an adult microbiome profile. If we looked at the bacteria within the stool, there could be over 1,000 different species of bacteria. And in our minds, we might think, oh, wow, that's complex. That's really a lot of different types of bacteria that could be in it. But it's actually not. If we went out and went to, Magnuson Park down the road, and we took a bit of soil sample and we looked at the amount of and types of bacteria in that soil sample, we'd actually see a much more complex bacterial types and numbers in that soil sample. And what that tells us is the bacteria within our GI tract have actually adapted to us over the millennium. So they have adapted to what we eat, our environment, and actually they have become a very essential and important part of us. So it's not actually complex. They're actually the types that we want in our GI tract. And if you look, they're actually dominated by two different divisions of bacteria, Bacteroides and Firmicutes, and that represents about 2/3 of the total gut microbiome. And I just wanted to talk a little bit about adult microbiome composition here as well, because we think, microbiome, it's a static word. It's, oh, that's the microbiome. But the microbiome isn't static. It changes. And just like children and infants, as their microbiome develops, what we do to our bodies, what we put in our bodies, the amount of exercise, the amount of sleep we get, actually affects the microbiome as well. So who are they? Well, they vary. They're plastic, which not actually plastic, it just means that they change well, and they're personalized. They're meant for each one of us. So my microbiome is very different from Teresa's microbiome, which is very different from Dr. Lee's. Dr. Wabe and I have been working so long together, our microbiomes might be the same, but really they're very personalized to each of us. And what they're doing is they're adapting to us. They're adapting to what we're doing to ourselves, what we're taking, the medications we're on, because they are a part of us. Now, why are they there? Again, they've been with us over the millennium, and as we've evolved, they have evolved with us. And they're there because they're a really important part of us. Just like our heart, our lungs, our skin, they make an important part of us as well. And they actually help break down foods for us that we are not able to digest ourselves. They make vitamins, and some of these vitamins are actually essential, meaning that we don't make them ourselves, and if we didn't have the microbiome, we may not get those vitamins. And they help protect us from bad bacteria within our that may invade us or cause health problems for us. So we like them and we want them there. We want those 100 trillion bacteria there. But we want to control them. We need to keep them in check, because if they don't go in check, that also causes problems. And so the body has built this amazing thing called an immune system to help protect us from the microbiome. And so we can get all the benefits without the problems. And one of the most important part is this outer and inner mucus layer. So these are microns thick. So they're very, very, very small, but they're able to actually keep the vast majority of the bacteria away from these epithelial cells, these linings of the GI tract, as Dr. Lee had showed us. And so the outer membrane lets a few extra ones in, the inner membrane lets fewer in, and then there are other things that, and remember this because I'm going to come back to this in a little bit. And there are other things that actually are quite important as well. So there are things called tight junctions. So these epithelial cells hold each other really closely with something called tight junctions, aptly named. And they actually make these proteins, bactericidal proteins, proteins that actually kill the bacteria if they get too close, because we don't want them getting too close. And if they even get closer, well, we actually have an immune system that actually sticks, this is an immune cell that sticks their long arm out there, grabs that bacteria and chews it up. Now, it does that not only to figure out who's bad and who's good, and I'm sorry, to kill the bad ones, but it actually does that to get a sense of who's out there. So even if there's not an inflammatory response going on, now and then the immune still sticks its arm out, pulls the bacteria in, chops it up, and figures out if that's going to be a good or a bad bacteria. So we have this system there to make sure that we're safe. And so how does the microbiome cause disease in humans? Well, the feeling right now, as I had mentioned before, that there are many different types of bacteria. All those little circles are bacteria. There are symbionts, so there are bacteria that are good for us, that help us. There's actually a lot of bacteria in there that are just commensal. They don't hurt us, they don't help us, they're just kind of there. And then there are some bacteria that are not good for us, or they're pathogenic, but they're in numbers that our body can deal with, and we're okay. So what happens is, in an inflammatory process like IBD, we feel that the microbiome, the bad bacteria, increase and then elicit the immune response, and you get inflammation and you get the symptoms of IBD resulting. So are there links, are there scientific links to the microbiome and IBD? And of course there are, because I would not be giving this talk otherwise. And what are those links? Well, some of them are quite soft links, meaning that they kind of point to the microbiome as being a part of what's going on, but they don't necessarily prove anything. One is that in IBD, we sometimes use antibiotics, for the treatment. Probably many of you have been on Cipro, Flagyl, maybe rifaximin, and they do help many individuals kind of with the milder symptoms. In Crohn's disease, and I think there's going to be a surgical talk later today, but in Crohn's disease, individuals who have really bad perianal disease or disease around the anus, if you do an ileostomy, so if you take the bowels and divert that fecal stream and have them have an ileostomy and poop into a bag versus down below, we know that actually quiets down the disease in the perianal area very significantly. Again, pointing to the bacteria, the microbiome, as part of the issue in IBD. And then there is serum reactivity towards microbial antigens. These are the serologies that many of you have heard of. We don't often get them because they don't necessarily change our clinical treatment often. But, oh, were you raising your hand? Oh, you got me all excited. And okay. Okay, I step back, sorry. So there are these blood work that can tell us that maybe the bacteria are involved. But two things that Dr. Lee had also pointed out: antibiotic use and the Western diet. And I'll just briefly touch on these. So in terms of antibiotic use, there was a phenomenal paper by a fellow named Crohn, who actually is here at Seattle Children's in the infectious disease department. And he looked at antibiotic exposure and the development of inflammatory bowel disease. And this is from a registry in the UK of over 1 million pediatric patients from a health system there. And he was able to look at how many people developed inflammatory bowel disease. And out of that 1 million, 748 developed inflammatory bowel disease. And because it was a health system where all the records were kept, he was then able to see who got antibiotics and who didn't. And what he found was that with antibiotics, especially if you were younger age, there was an 84% relative risk increase. Now, that doesn't mean 84% of people who got antibiotics developed IBD. It just means that when compared to individuals who didn't get antibiotics, that's where the 84% increase was. It was still fairly low, and obviously people who did not receive antibiotics also developed IBD in this cohort study. The other interesting part of the study was the younger you received antibiotics, the more likely there was a chance of developing IBD. In addition, the more antibiotics you received at a younger age, the more likely you may develop IBD. Now, I'm not saying, and this is part of sometimes the dilemma with research, is I'm not saying we shouldn't use antibiotics, because antibiotics are essential to making sure people do well. And without antibiotics, there would be a lot more in terms of mortality and morbidity associated with bacterial infection. It just shows you that there's a link to antibiotics and IBD. In addition, Western diet was shown to induce dysbiosis with an increase in E. coli in CBAC10 mice. So it would be wonderful to be able to do a study like this in humans, but obviously you can't, and it would be inappropriate to do so. But this, in conjunction with what Dr. Lee showed on his slides, again, points to a more Western diet as being problematic for individuals with IBD. And as we know, diet also changes the bacteria within our bowels. And so this is a very busy slide. But there are a couple of things that I wanted to point out here. And, oh, yes, you are so kind. Thank you very much.
What constitutes a Western diet?
That's a phenomenal question. So these mice were fed high-fat, high-sugar diets as compared to the controls in the study. And that's actually one of the difficulties with some of the studies in nutrition that we're doing as well as others, is that diet is a fairly all-encompassing word. We know that diet, quote unquote, affects our microbiome, but to figure out the best diet for individuals can be quite difficult because, just because you're eating let's say, can't think of anything, just because you're eating a sandwich, one individual sandwich may be very different from another individual sandwich in terms of the different components in there, the different spreads on it. And so diet is a very difficult thing to control for in studies. Happily enough, we're going to be doing that in a very short while. We have a study coming up, not until September, hopefully, but where we'll actually control literally all the food individuals eat. Not because we're putting our overreaching arm into people's houses, but we're actually getting a chef to make all the food for families. So hopefully we'll be able to address that question later on. But with that being said, high sugar, high fat in general. And it did a couple of very interesting things. And again, these are quite difficult to see here, but if you look right, Claudin 2 is a protein which kind of punches holes in the epithelium, in those cells lining the GI tract. And that's bad because if you're punching holes in your epithelium, the bacteria are able to get down into the epithelium and cause an immune reaction. So in mice, again, this is mice, not humans, but in mice, what you see is that on a conventional diet, you don't have that protein which punches the holes in the epithelium. But in the high-fat, high-sugar diet, you see all of this Claudin 2 being upregulated, meaning that it's punching holes and allowing bacteria, at least in animal models, to get to the epithelial lining. What it also does, and this I think may be just as important, if not more important, is that MUC2 or mucin 2 is the protein that actually makes that mucus layer. And as I had pointed out before, the mucus layer is so important in terms of keeping that bacteria from getting to the epithelial lining. And so what this study shows you is that the conventional diet, you have a nice amount of mucus there. It's all red. We like red. But here, in the high-fat, high-sugar diet, in, again, an animal model, we get much less mucus. And this is one time in the world that we like mucus. So diet does affect the GI tract, as well as in this study, we saw an increase in E. coli, which is sometimes felt to be part of the problem and causing some of the inflammation in IBD. Yes?
So do the emulsifiers kind of work in that same way?
So that's a great question, and I swear I did not plant you here. And I actually took those slides out because I didn't think, you know, part of the problem with talking about diet and nutrition is that I don't want people to get over anxious about foods, but I do think that diet is an amazingly important thing to remember. So emulsifiers do very similar things. So I apologize, what is your name?
Dave.
Dave, phenomenal name. The emulsifiers are additives into foods, and there are a number of different emulsifiers, and there have been some really interesting paper coming out lately looking at emulsifiers in foods. And emulsifiers actually didn't come into our diet in a major way until probably the 1930s and 40s, again, around the time that we start seeing an increase in IBD. And emulsifiers are detergent-like molecules, so they kind of break down that mucus layer a little bit. The problem with emulsifiers also is that they're pretty ubiquitous, meaning that they're in most foods, and you probably wouldn't know that they're in the foods. Sometimes they're called modified cornstarch. Sometimes they're called emulsifiers. But yes, they do very similar things. They also change the type of bacteria within the bowel to what we feel is more inflammatory. And they do show in genetically susceptible animals that there is an increase in colitis. So yes, it does very similar things. Yes.
So is emulsifiers like a preservative then, or I mean, how to be?
So emulsifiers are used in many different for many different reasons. Primarily, they can help preserve, but they're usually there to give a different thickness or texture to foods. They're often in ice creams and things of that nature. Now, so it'll be noted, you know, emulsifier. Actually, last night my wife got out the ice cream. So, oh, there it is. Kids still ate the ice cream. But with that being said, you know, do these things play a role in IBD? Likely, the significance of that is hard to know because it's probably not just one thing. For instance, maltodextran. Maltodextran is an emulsifier that has been shown in animal models as well to trigger IBD. But on the flip side of that, we use EEN, or exclusive enteral nutrition, which I believe Kim is going to be talking about later today. And there just happens to be maltodextran in the formulas. It still works fantastically. So, you know, EEN is an amazing treatment that really does work. So it's not one thing that is probably evil or the bad guy. It's probably many things put together in the right context that cause the inflammation. So other links from the microbiome to IBD. So this is from a number of studies, but they've shown a decrease in microbial biodiversity. So it decreases the types of bacteria in the GI tract. And as we probably can guess by looking at, let's say, other areas of diversity, such as the reefs that we see in Australia, or just in cities, right? Diversity is a good thing. And in IBD, there is a decrease in diversity. Decrease in the commensal bacteria, the type of bacteria that seem to not neither harm or hurt. Harm or help. There also is a dysbiosis with a higher concentration of mucus or mucosal-associated bacteria. Again, more bacteria getting closer to the epithelium, that lining of the GI tract, which can then cause an inflammatory process. And an increased number of mucolytic bacteria, so actual bacteria that's able to break down that mucus lining. There's also an abundance a reduction in the abundance of butyrate and propionate bacteria, or producing bacteria. And why is that important? Because propionate and butyrate are important for the overall health of the GI tract. It's an important nutrition source for the colon. So we're thinking about IBD, and when we think about IBD, again, there are different components. There's the immune component and the microbiome component. And right now, primarily, we treat IBD by treating the immune component. And as Dr. Lee pointed out, it's important because the most important thing, no matter what, is getting your child or the patient into clinical remission, no matter what method one uses. But that's the method that majority of places use right now, and appropriately. But the next question is, can we flip that question a little bit and actually affect the microbiome and get rid of the bad bacteria and make it happy, and also make patients with IBD improve? And I think the answer is yes. The research is very, some of it's a little bit older in terms of EEN, some of it is just emerging. So this is a study on, can diet change your microbiome? And this isn't in IBD patients, and it's a little bit of a complicated slide, but you're just going to have to take my word for it. Yes. Diet has a big influence on your microbiome in very positive ways. And so before I talk about the SCD and other diets, the area that we have the best knowledge on in IBD is EEN, or exclusive enteral nutrition. And that's primarily for Crohn's disease, or for Crohn's disease. It's not actually used in ulcerative colitis. But it's not only been shown to work as well as steroids, but actually in some ways maybe better. And so I'll show you these pictures right now. So this is a study by a fellow named Borelli, and what he looked at was individuals with active Crohn's disease, and he gave them EEN and then followed up. But the reason why this study is just a phenomenal study is that he did ileocolonoscopy. So he not only looked at what their symptoms were and their laboratories were, but he actually did a repeat endoscopy and colonoscopy and looked at the healing of the mucosa, which is actually an important goal for the treatment in IBD. And what he showed was that, and again, you'll have to take my word for it, but the PCDI, which is the validated score for inflammatory bowel disease, both of them were very elevated and pretty much the same at the beginning, and both of them at the end came down beautifully, and both groups went into remission at the same rate. And when we looked at labs, again, before the treatment, both groups exactly the same. At the end, both groups exactly the same. So this is good. So we know that it works equally well as steroids. But what really was impressive about the study was when he did the histologic score, so the biopsy, how he rated the inflammation on the biopsy. And what you see here is that in the formula group, the polymeric group, that before and after there's a very significant reduction in the inflammation. Not as much in the steroid group. It did come down, but again, not to the degree that the formula-based group went down. So that gets you excited. That says, oh, wow, you know, nutrition, diet does play a role.
Oh, I'm sorry, could you go back?
Oh, yes.
Curious on how the weight do.
How did the weight? Oh, wait.
Formula, right?
I'm sorry?
Because EAN is just a liquid.
It's a formula, yes.
Yeah. So did they actually go
So the weight actually went up in both groups. The weight and both were statistically significant. The weight in the they actually went up proportional. So this was 33.9 to 37. This is 30 to 34.7. So probably around the same amount.
Don't you retain more water with steroids?
You do. Yeah, you do.
That doesn't count.
So yeah, so the weight, right? So when you think about weight, you know, you think about, you know, many things can affect that. So we don't know if the weight was necessarily better for the EEN group versus the steroid group, although hypothetically you would imagine that it would be, although this study doesn't address that question.
Yeah, I just.
Yeah. So this is another study, and this study came from a fellow out in Israel by Ari Levine, and this used a similar kind of concept of EEN, which you take out all the you take out all the food and you just give formula, but instead of doing that, he gave partial EN. So some of the diet was just this formula, and some of it was an exclusion diet. And what he did was 47 individuals were eligible, and then out of that, about 40 went into this group, which is the formula with the diet, and 27 individuals went into remission, and 3 had response but not remission, and then 10 failed. But what I thought was fascinating about this study was that there were some individuals, 7 to be exact, who did not want to take the formula. I don't know why they didn't want it, but they didn't, and they just did the diet. And out of this group, 6 went into remission, and 1 had a response. Again, pointing that diet itself may be a treatment for IBD. And when we look at the numbers themselves, this is something called the Harvey-Bradshaw Index. You'll have to take my word for it. Really improved, PCDAI, active disease, in remission, so again, really improved, and inflammatory markers coming down as well. So all in all, diet, nutrition does play an important role in IBD. And then it comes to the specific carbohydrate diet, and this is an area of interest for me because I've seen it actually have quite profound effects. It's not something that necessarily works for everybody, and it's not necessarily right for everybody, but you should know that it's something that we do here, and it's an option for people if interested. It's a diet which removes all grains, all milk products except for yogurt fermented greater than 24 hours, and sugars except for honey. And it's a diet that actually started off treating patients with celiac before we knew what celiac was. And this was in the 1930s. A fellow named Sidney Haas first published on it. And then Dr. Haas treated an individual, a child who was the daughter of Elaine Gottschall. He passed away, and it kind of fell out of the medical world. And she wrote a book and was a big advocate and kind of continued it on. And now we're taking up that research here at Children's. So we started our research with a retrospective study, so looking back at individuals who had gone on to the diet. We had 7 individuals, and their ages ranged from 7 years to 16 years. They had, all of these individuals had Crohn's disease. Some had mild, some had moderate, 2 had severe. And individuals were on the diet anywhere from 5 to 30 months. And what we saw, again, it's a retrospective study, so it's not necessarily as strong as a prospective study. We saw that they had active disease to begin with. And at 3-month follow-up, all of them had no active disease. So they all had done quite well clinically. But what also intrigued us here at Children's was that the inflammatory markers, the markers that we look to see if there is ongoing inflammation, came down, and for the vast majority stayed down as long as we had been following these patients here at Children's. We also saw the albumin. Again, albumin is a little bit different than the inflammatory markers. Inflammatory markers, high is bad. Albumin, low is bad. And so they started off low for many and normalized for most, except for this one individual. And blood level also seemed to improve for a majority of people in this retrospective study. So that got us thinking, well, in a retrospective study, it looks pretty interesting. So we then started to want to look a little bit further. And so now we have a prospective study that's ongoing. And this we opened to both individuals with UC as well as Crohn's. And all of the individuals have finished the study except for this one individual who was not able to. Because again, this therapy may work. And may work quite well, but it doesn't necessarily mean it's right for everybody. And it wasn't right for him. It was quite difficult for him to maintain on. And so what we saw here was that people above the red line is active disease, below the red line is remission. And so the vast majority of individuals went into remission. And the majority of the people in the study have continued on the SCD. We also see inflammatory markers normalizing for individuals with both Crohn's disease and ulcerative colitis. And the study also shows stool calprotectin, and as many of you remember, that's the inflammatory marker for the stool. And what was interesting about this was that they all came down except for 2 individuals, which were a little bit confusing for us. So this individual has continued on the diet. And actually, after this one, I think about 2 weeks later, we got a repeat calprotectin, and it had normalized. So we're not really quite sure why this spiked, but it has come down and has stayed down. And then this individual, we saw, again, starting high, coming down low, and maybe bumped up a little bit right there. This individual actually started breaking the diet about 2 to 3 weeks before this. So that may be why that bump is there. And that individual actually, I take back, this individual actually has decided not to continue the SCD diet. Oh, yes. So we are, see, I talked way too long. The microbiome has been shown to change in the specific carbohydrate diet. This is a study in people who were healthy and had no active disease, but it actually improved the diversity. And as I was mentioning before, we actually have an active SCD program here, and even if you don't want to be on the study, we'll support an individual if they're interested. There are other diets out there. There are many, or not many, but there are a few other diets that have been put into the literature. And right now we know the SCD and we feel like the SCD really works from our experience and the research that we're doing. But part of the question is why it works. And as I had mentioned before, we actually are going to move forward with a study where we have a chef produce different types of meals for individuals and see how individuals do thereafter. So there's a lot more exciting research that should be done and will be done in the future. So, in conclusion, the fecal microbiome is complex and biologically important in IBD. The fecal microbiome modulates us, and we can modulate the fecal microbiome. Thank you.
Thank you, Dr. Suskind. That was fantastic and some great information. I just wanted to take a moment real quick, and then we're going to take a break to introduce myself. My name is Kristen Baxter, and I manage the Take Steps fundraising walk program here in the Northwest. There are flyers in your folder that you received today for the Western Washington Walk, which is coming up on June 7th. And I'd just like to point out a few things about the fundraising walk that we put together. First, it's a ton of fun, and it's a great way to really become a part of the IBD community here in Western Washington. We do games and activities for kids. There's live entertainment, some food, and then, of course, there's a family-friendly 2.5-mile walk. And I like to share the distance because it's not a huge walk. It's manageable for everybody, but it's really just a good time for us to get everybody together and sort of celebrate our patients and their fundraising efforts leading up to that point. This year, our honored hero is Luca Stash, who is an IBD pediatric patient, and he's also a Camp Oasis camper. So he's going to help us. We'll have a station at the walk that's specifically for Camp Oasis campers where they can get to know each other and do some activities prior to leaving for camp a couple weeks later. And I like to point out about our Take Steps walk that over 90 cents of every dollar that we raise at the walk goes right back to our mission efforts. So to be able to put stuff like this together, Camp Oasis and our other support programs that we provide throughout the area, you can register as an individual, or you can put together a team and walk with your friends and family and coworkers, come up with a really fun name. And I have to say that some of our team names are fantastic. You can wear team t-shirts and just kind of rally the troops to come help us raise awareness. So that is coming up on June 7th. Again, there's a flyer in your folder, and I will be here all day. So if you have any questions about the walk or the program, please let me know. And so I think we're going to take a 5-minute break and come back here. Thanks, everybody.